E diamo la parola al professor Roques, che è il coordinatore scientifico dell'altro gigante, diciamo, della ricerca termale in Europa, quindi che è la fondazione, la FRET, che è l'associazione per la ricerca termale in Francia. Prego, professor Roques. Il professor Roques è una persona, è un esperto di riabilitazione, è stato partecipato ai programmi OMS sui problemi del low back pain, quindi i problemi legati a tutti i problemi della spina dorsale, di tutti i problemi della colonna vertebrale, e quindi è un sostenitore importante delle cure termali. Prego.
Sì. Buongiorno a tutti e grazie Umberto per la tua invitazione. È sempre un piacere di essere qui in Italia, un paese molto caro per me, un paese di molti amici, un paese di buona vita, un paese di una bella lingua, molto musicale e molto difficile. Molto difficile. Parlerà in inglese, sarà più facile. So I will, during this lecture, will pay a short attention to the problem of the thermal care in France, which are not very different from Italy, and to the training of the doctor especially. And the main part of my lecture will be dedicated to the scientific investigation we are performing now in our country. Okay. In France, more than 90% of the activity of the thermal resorts is dedicated to treat patients with chronic diseases with the financial intervention of the social security. So, spa therapy is in France a medical treatment needing a medical prescription and needing a medical supervision during the delivery of the treatment. The treatment is one single session of 18 days of care, 3 weeks, not 2 weeks as in Italy. And the treatments in our country are based on 3 fundamental elements: the hydrothermal cares, drinking, bathing, showering, mud application, and so on. The second part is rehabilitation, using mineral waters. And the third part, which is developing more and more, is patients' education. These last years, the number of patients treated in the different thermal care facilities have strongly increased in our country. But the main conditions treated remain rheumatic conditions, which are painful conditions. To have a thermal treatment needs a personal financial engagement of the patients, as they have to afford by themselves the main expenses of traveling and of staying in the resort. And the intervention of the social security is mainly dedicated to the reimbursement of the thermal cares and of the medical supervision of the thermal treatment. For the patient, the compensation is to have a better shape, and for the social security, the compensation is that the thermal activity implements taxes and social contribution. And the balance between what the social security has to pay and what the social security and the state can gain from thermal activity is significant. In our country, we pay a very little attention to medical hydrology during the training of all the doctors, during the second cycle of the medical training. And this last second cycle is closed by a competitive examination for all the French students, which are classified. And according to their classification, they will be able to choose what specialty they will exerce and in what city they will be able to be trained. And in the program of this examination, we have only one specific item which speaks of thermal treatment, but we can also introduce references on thermal treatments in several other chapters concerning rheumatic condition, digestive condition, urinary tract condition, and so on. We have also a specific training in medical hydrology, which is very useful but not compulsory to be a doctor in a spa resort. And now there are about between 30 and 40 doctors. We are in this training to become a specialist in medical hydrology. Training is not only the concern of the doctors, it's also the concern of allied professions, especially pharmacists, nurses, physiotherapists, and so on. And we have also the problem of the training of the caregivers, which is quite well organized in our country. But in the training of the health allied profession, very poor or known attention is paid to medical hydrology. And this is the cover of the book, which will be published in 10 days. We have written with many co-authors and concerning the data, the scientific data of balneotherapy, which will be, I think, an help for the training of the different professions. But the main part of my lecture will be dedicated to a scientific investigation. As told before, my friend Marco Vital, France and Italy, which are twin countries for many things, are also the only country to have specific foundation to support scientific investigation. And in Italy, you are most dedicated to the basic sciences investigation. In France, our aims are different because this foundation was created on the demand of the social security, which told to the contractors, we will pay for the treatments you deliver to the patients, but you have to demonstrate that you are giving a medical benefit to the patient for whom we are paying. And so the dedication of our foundation is to the demonstration of the medical benefit. We have at this time fully implemented 13 call for projects with a total financial engagement of 13 million euros in about 50 scientific programs from more than 100 programs submitted. And as you can see, most of these programs are dedicated to the demonstration of the actual medical benefit. Scientific research is not a long, quiet river, and we had failures. And especially, we had failures in assessing the thermal treatment in respiratory conditions, ear, nose, throat conditions, or COPD disease. We had also failures in patients with low back pain with sick leave. And this problem points that the difficulty of clinical investigation is to enroll patients. And it's easier to enroll patients to take a tablet every day than to go to spa for 18 days. But we had also some success. And for example, we have at the time published 5 large randomized controlled trials on different topics such as general anxiety disease, osteoarthritis, overweight, obesity, and chronic venous insufficiency, chronic shoulder pain, which demonstrated in every situation the interest of the thermal treatment. We have also investigated the situation of new trends of innovation in balneology, and innovation in our country is based mainly on prevention, and on prevention using the particular means of therapeutic education of the patient. And so we had some investigation in post-cancer, in metabolic syndrome, cognitive decline, psychotropic drugs withdrawal, physical activity, and also I spoke of chronic low back pain with sick leave. And for all these conditions, we could have papers in good journals. We have also some works which are under press concerning mainly education. We have also a lot of studies which are in progress concerning psoriasis, fibromyalgia, physical activity, upper limb musculoskeletal condition, and also a short number of studies on physiopathology concerning mainly the role of hydrogen sulfide and the mechanism of action of balneotherapy in very particular conditions such as generalized anxiety disorder. We have 8 randomized control trials which are ongoing, and it's a big business to organize all these trials. And as you can see, they will concern post-cancer, chronic low back pain, and multiple sclerosis, urolithiasis, sleep disorders, and so on. What can we demonstrate from these different studies? That we had clinical benefits. We had a lot of investigation dedicated to aging, and also some dedicated to the medico-economic approach. First, we observed that thermal treatment was analgesic treatment. Analgesic for patients with rheumatic condition, with patients with chronic venous insufficiency, and that these patients who had less pain had a better function. And you can see the effect size of the thermal treatment on pain. It's a very significant effect size, as it is in most of the cases above 0.80. We also demonstrated that thermal treatment was a significant helper to cope with stress-related disorders, in the case of general anxiety disorders, but also after cancer, for patients with addiction to psychotropic drugs, and also for patients with poor sleep. And in this different situation, we could demonstrate a benefit for thermal treatment. We also could demonstrate that the thermal treatment was a very useful time to control metabolic problems, such as overweight and obesity, and also a more particular condition, which is the metabolic syndrome, which is the gate to several conditions as hypertension, chronic vascular disease, and particularly neurological and heart chronic disease, and also, of course, of type 2 diabetes. And in all these situations, we could observe a significant improvement of patients after thermal treatment. As I told you previously, the time of the thermal treatment, 3 weeks, is a very good time for education. There is informal education from the discussion of the patients with the caregivers and the doctors, the informal education from the discussion of the patients between them in the thermal park, which is the first community of patients, and also formal education from therapeutic education programs which are developed and delivered during the time of the treatment. And so we could, in patients with stress-related disorders, with chronic venous problems, with cancer, and with metabolic condition, we could demonstrate the interest of this educational approach. And we could set the patients who had a better general condition, less pain, more function, better stress coping, better weight control, were happier in their life. And we could measure that their quality of life could be improved in rheumatic conditions, in venous problems after cancer, or with stress-related disorders. Aging was a special concern, and we dedicated a lot of studies to aging, on the prevention of cognitive decline, on the identification of the risk of frailty, and on the importance of physical activity and nutrition for all persons, and falls prevention. In all these situations, we have, or we are organizing investigation programs. Some years ago, we had a huge questionnaire with more than 100,000 people answering the questionnaire. And in this questionnaire, they related that 97% of the treated patients had lasting effects. And lasting effects were effects that were lasting at least 6 months. And in these lasting effects, they were speaking of less physical pain, they were speaking of less drugs consumption, they were speaking of less doctor's consultation. This was declaration, and we tried to verify with objective measure if it was really the case. And we launched several investigations with some disappointing results. Concerning clinical endpoints, medico-economical endpoints in clinical trials, for knee osteoarthritis, we didn't observe an improvement of the financial dimension. For shoulder pain, we observed that the patient used less anti-inflammatory drug topics. But for post-cancer programs, we observed that at 6 months after the thermal intervention, the women who had returned to work had a significant gain on health expenses. And at 1 year, the gain on health expenses was significant for all the women included in the program. And in this study, we have been able to measure 5 years after the program, and the improvement of the quality of life remained significantly better in the women who had benefited from one time of the thermal intervention. We have also to discuss, to finish, some methodological issue. Our concern in clinical investigation was to have scientific power, a sufficient scientific robustness. And so the basis of the statistical power is the number of patients to enroll, which has to be calculated before the enrollment of the patients. And in most of the cases, we could, for the different randomized control trial, success in this parameter. The second is to perform an intention to treat analysis in which the patients are analyzed in the group in which they have been included at the randomization, whatever have been their approach of the treatment. And in most of the cases, we could perform such an analysis. I have compared the number of patients enrolled. In 2006, we organized a meta-analysis which summarized 46 randomized control trials. This 46 randomized control trial had enrolled 2,700 patients, 14 years of investigation. From our creation, 14 years of investigation, 11 randomized control trials. We have enrolled approximately the same number of patients. So as you can see, the number of patients we have enrolled is strongly more important than what is published in the international literature. And this is a crucial point to have the statistical power. So enrollment is a problem, and there is no general rule, there is no paradigm, there is no panacea. Mass media can be efficient and cannot be. Specialists usually are not very efficient. GP are not very efficient. And what is easier is to enroll the patient when they are arriving in thermal care facilities, but we cannot demonstrate the medical benefit of the thermal treatment. We can demonstrate the benefit of a particularity, a peculiarity in the thermal treatment. So we have no paradigm for all the investigation. The efficiency of the treatments can be measured with different factors such as effect size, and we could observe that, for example, for pain and or for quality of life, we had significant effect size if we consider that the patients were assessed usually 1 year after the thermal treatment. But another way to assess the efficiency of the treatments is to measure the number of patients we were able to reach some thresholds of efficiency. These thresholds are levels in which the condition of the patient and the life of the patient is changing. For pain, it's minimal, clinical important improvement, MCIA. For anxiety, the level of responders is improvement of 30%. For the weight, we know that when a person has lost 5% of his weight on a stable way, he is able to increase his expectation of life. All sorts of deaths confused. So we could observe that when we use this threshold of efficiency, we get good results with the thermal treatments. These are the different publications which have been published in English reviews with impact factor. So, and for example, for our clinical investigation, we could publish in very good journals, such as the first review in rheumatology, in vascular disease, the first European journal for oncology, and the other are English-speaking reviews with impact factor. And all of you have good knowledge of these different journals. So, in conclusion, spa therapy, medical spa therapy, is a complementary medicine, of course, but it's a scientific medicine. And the cares in countries such as France, Italy, Spain, Portugal are given with high standards of quality. Education in many countries, education especially of the doctors, is a very problematic issue. But we need to have a substantial number of scientific study to bring to this education, to this training. And we are lacking of this compendium. So research has to establish, of course, the medical benefit of balneology, the medico-economic impact, and also the explanation of the way by which the patients are improved. Thank you for your attention.